Welcome, everyone. Thank you all for attending today's patient data panel. So today our panelists will be discussing both exciting opportunities with utilizing patient data, as well as the associated risks and algorithm biases. Some quick logistical notes. We're going to start the panel with a moderator Q&A to be followed up with about 10 minutes of a chat with Q&A from the audience as well. So please feel free to enter in any questions that you have in the Q&A feature so that we can get those questions answered. And with that, it's my pleasure to introduce Professor Dan Benjamin. Professor Benjamin holds joint appointments at the UCLA Anderson School of Management and the Human Genetics Department at the UCLA David Geffen School of Medicine. He is a co-founder and co-director of the Social Science Genetic Association Consortium, a multidisciplinary enterprise that provides a platform for collaboration between geneticists and social scientists. Professor Benjamin's background is in behavioral economics, where his research incorporates ideas and methods from psychology into economic analysis. His research on genoeconomics develops tools for incorporating genomic data into the social sciences. Prior to joining UCLA, Professor Benjamin was a faculty member at Cornell University and at the University of Southern California. As if that wasn't impressive enough, he also earned his PhD in economics from Harvard University. You'll also be hearing from our esteemed panelists, including Katie Rose Skelly, the co-founder and CTO of Known Medicine, Jim Best, a proud UCLA Anderson alum and a limited partner at Wavemaker 360 Health, Marinka Natale, the CEO and data analytics strategist at LynxIQ, and lastly, Vijaya Vishwanathan, a director of product at Episource. So without further ado, I'll hand it over to you, Professor Benjamin.
Thanks, Caroline. So we're going to try to keep this as relatively informal as we can, given the formality of a Zoom format. And let's start with making sure we're all on the same page. So I'm going to ask Jim, how would you define precision medicine?
So first, thanks so much for having me. I think precision medicine is a remarkably nebulous term, as we're probably about to discover. And for me, several definitions come to mind. So I'll just, I think, give an example of what I'm most excited about in this vast field, and that's prescription digital therapeutics, AKA digital therapeutics, AKA software as a medical device. So this is a nascent industry in which companies are receiving FDA approval for software that treats people. So these are not just wellness apps. Many of them are mental health applications. And I'll use autism spectrum disorder as an example. So Cognoa is a company that I'm following closely because I have a nephew with autism. They're going to market soon with a digital diagnostic, and they'll eventually follow that with a digital therapeutic. So the diagnostic uses an AI that was trained by data from about 20,000 patients. So that allowed them to see for the first time what signs, symptoms, comorbidities, et cetera, are more signal than noise. So I would argue that Cognoa's diagnostic does represent precision medicine, but it's just one of many examples. So why does it matter? Cognoa ultimately should allow a much easier, faster, cheaper path to getting these kids diagnosed, which is critical because this affects about 2% of kids, and waiting lists for the traditional diagnostic process ranges from 2 to 16 months. And that waiting severely compromises prognosis.
So, and what's the precision part of that?
Yeah, I would say that, the AI that they used with those 20,000 cases used all kinds of different data points to distill the hundreds of factors that used to be used in diagnoses down to a more manageable number. And I think later on as we talk, I'll talk a little bit more about how data can be integrated into those, into their data, and how we can get even more precise than that.
Got it. Does anyone else want to jump in on precision medicine? I mean, I think Vijaya?
Yeah, sure. So to me, precision health means looking at a patient or a member holistically. So not just looking at their health data, but looking at their environmental data, looking at SDOH factors, looking at their pharmacy information, looking at what kind of other treatment they are getting, and combining that with innovations and technology that help us basically provide targeted and personalized care. So driving care precisely where needed and the way it's needed with innovation and technology is what precision medicine means to me.
Yeah, go ahead, Marinka. So you want to jump in? Everyone should just jump in.
Yeah.
No, that's great. So that's very much similar to the way that I've experienced precision medicine. And by combining all of this information together, and genomics is a great example of that, you can provide better effective care, right? So in breast cancer in women, HER2 positive versus negative will have a different outcome if you're given Herceptin as an example. That's a known case. And things are changing every day, but essentially the goal is to try to, from multiple data points, establish and learn about how to create clinically similar or identical cohorts that are much more specific than just, let's say, mental health or cancer, right? And then be able to learn from that so that you can improve the quality and outcomes of the care that's provided.
That's great. Yeah. Oh, go ahead, Katie Rose. Oh, you're muted.
I think my definition is similar to a lot of what's been stated here, though. It's really identifying what patients need what care, rather than really looking at like this group of patients, trying to get as specific as possible and as personal as possible to really, on an individual level, identify, to Marinka's example, what type of drugs a patient needs, or what type of physician interventions they might need, or what type of preventative care they might need on an individual or on as individual of a level as possible.
Great. Those were all fantastic, helpful answers. So a key part then of doing this kind of precision healthcare or precision medicine is identifying the types of people who are going to benefit from particular kinds of interventions or prevention strategies or whatever it may be. So a big part of that has been algorithms, machine learning, artificial intelligence. So Katie Rose, maybe you could tell us a little bit about what your company does with developing machine learning to help with precision medicine.
Yeah. So essentially what we do at Known Medicine is we get a piece of a tumor from when it's, cut out of a patient during a resection. We break that tumor down into thousands of microtumors, and then we dose each microtumor with different drugs and identify which drug works for that individual patient. And we can do this, a lot of our outcomes can be machine learning based. So really identifying which cells are being most affected by the drugs, and that's a portion that's machine learning based. But then we also have this opportunity to really identify trends, to really identify which groups of genetic markers are most predictive of response on our platform, and really say, okay, we've run these 500 patients and we have, mutation data for these 1,000 genes, and we have 100 drug responses for every single one of these samples, or 200 drug responses for every one of these samples. What combinations of genetic factors or environmental factors or, like patient backgrounds are most predictive of response to this single drug? And as we grow that data set, we get better and better at being more specific about that and as personalized as possible there, to really, rather than having patients go to the doctor and be told, yeah, you have this mutation, you have a 30% chance of responding to this treatment, but it's definitely your best option. Really being able to test to really identify which drug is going to work a priori, to really get better and better and more specific at understanding exactly who will respond to what drug.
Great. So data is really important then on two ends. One is the data for the training, the machine learning or AI or statistical methods or whatever it is that's going to identify, help you identify how to personalize the treatment. And then it's also important on the end of the actual patient or customer who you're going to use the data for. So, I mean, maybe Jim, do you want to say something about how data comes into what your company does?
Yeah, rather than talk about Wavemaker 360 Health, though, I'd rather talk, I think, about my past role at Komodo. I used to run the MedTech group for Komodo Health, which is a SaaS company that gleans insights from insurance claims data. So there's a lot to say here. Sorry if I get a little long-winded, but at baseline, just using claims data, what could a company like Cognoa do? Health economics teams can see how much money is saved with early diagnosis. Medical affairs teams can assess the extent of the digital therapeutics clinical effectiveness. Marketers can hyper-segment patients and physicians. Sales teams can identify payers and health systems with the biggest ASD burdens. The list just sort of goes on and on and on and on. So what's really wild that's happening right now is that data sets are being linked together at the patient level. With Komodo's software, you can take Komodo claims data and augment it with all sorts of data. So lab results, mortality, EHR, race and ethnicity, genomics, and most importantly, perhaps, the data that's being collected by companies such as Cognoa. So we can gain this incredibly rich picture of what's going on with these patients, and we can track them on a patient-by-patient basis over time to see changes on massive scale. So let's say Cognoa decides to marry their patient data to just two different data sets, so claims data and genomics data. What does that enable? So perhaps we know from Cognoa's data, and I'm not speaking for them to be clear, the behavioral and communication characteristics of some child. We know from the insurance claims how much and what type of healthcare utilization is going on for that kid, all the dozens of other potential factors that are in the claims, including diagnoses, and then for the genomics, ASD is a highly polygenic disease, right? It doesn't follow Mendelian rules. So perhaps when you marry these data sets, the AI algorithm improves so much over time that Cognoa is able to define ASD subtypes, which unfortunately had to be removed from the DSM back in 2013 because they weren't actionable. Or perhaps you'll see certain genetic markers that help diagnose even earlier or inform how these patients should be treated with a digital therapeutic. So bottom line, the future state of data insights is that these companies may ultimately have hundreds of potential treatment pathways based on all the data that's being input.
Marinka, you want to say something about how LynxID uses data?
Yeah, so LynxIQ works with companies.
Sorry. Yeah, so I meant LynxIQ.
To essentially, exactly as Jim was saying, to help them understand how to leverage their data to build a better solution that it addresses the cost drivers, addresses the better, and helps improve outcomes. But it's not just about doing assessment and research and creating models, but it's also more important understanding the applicability and the actionability of that information, right? How do you apply it? How do you have users use it? How do you actually help a patient get better using this piece of technology or this bite of information? Some examples that we've worked with other companies on are using location data, for instance, on your phone to increase and improve accessibility to care for people who have accessibility issues and mobility issues. Using non-clinical data that, where one person will leave the hospital or the office in the care setting, and then that they just drop off the face of the earth, right? So taking non-clinical information and combining it, as Jim was saying, and others, so that you can understand where the actual care gaps occur. Genomics testing to ensure drug efficacy in cancer and mental health now. It's amazing. Like, why trial and error on what will help treat and affect and resolve depression when you can actually have a test that tells you these 3 things don't work for you. And then finally, another one was sentiment data to improve and promote behavior change. How do you get someone to stop smoking if they really don't want to? What are the things that maybe might affect them and influence them to as an incentive to actually stop the negative behavior? So it's not so much that some of these concepts are new, but it's that we're able to leverage so much data using AI, using algorithms to focus in on the key factors that really can make a difference and that can really promote better care. So that's what's really exciting from my perspective.
When we have all this data on people want to know how it's being used. They may not want it to be sold to third parties, or they may, at least if it is going to be used by third parties, they might want to know how it's going to be used. I mean, Vijaya, do you want to speak to some of these transparency issues?
Yeah. So as a B2B org, we basically get tons of data from our payers or health plans and providers who are also risk bearing. And we use all of these data to what Marinka and Jim alluded to, right? We use all of this data for data analytics. How we maintain transparency, one way is we basically share everything we are doing. We have cloud-based SaaS applications that basically show our partners how we are using their data, what algorithms we are running them through, and maintaining complete transparency on which data point drives what outcomes. So, for example, using claims data, as Jim was saying, to drive whether a patient has had an annual wellness visit or not. Using those kind of correlations and sharing all of that information very transparently has been our go-to for this kind of information. Also making sure that we have safeguards around it so that data is not misused, right? Granting access as needed only, using single sign-on, all of that has also been something that as organizations we have focused on. We use the data for the purposes that is intended. So raising gaps, raising awareness, and using that to drive actionable outcomes. So that's how we have been doing it at Episource.
Does anyone else want to say anything about how you ensure transparency of and how you treat customer data? Or privacy? I mean, another issue that comes up is concerns about privacy and whether the data, how you're going to make sure that you're not learning too much about any one person, or be able to identify them, or be subject to a data leak, maybe the nightmare scenario. Katie, Rose, or Jim, or yeah, go ahead. No, I was
going to say that there are protocols in place. There's a lot of laws and things that you have to do to get accredited to make sure that you're using the right methods and security. So to maintain that privacy. HIPAA is just one example, but there's high trust, there's SOC 2, there's all kinds of things. And to be quite honest, if you're building a system, there are so many ways that you can encrypt or decouple information about a person while still capturing the attributes that you need in order to do the analysis. So it's not rocket science. I don't know if anybody else wants to speak to that.
No, you're right, Marinka. So we have BAAs, NDAs, everything that you can talk about around every single data contract. All data is encrypted. So all test environments have data that is completely anonymized, no PHI anywhere. So we go through high trust certification every year, and we have to maintain that. So organizations that handle healthcare data, databases have to be super secure, and access to production data is limited to only as needed.
Yeah, and I'll add, I think that I mentioned earlier that companies like Cognoa can buy data at the patient level, right? So obviously we have to ensure that data users cannot re-identify the actual patient. So drilling down into what Marinka and Vijaya are talking about, what can a data user see about the patient? In lieu of a name, every patient, at least for the Komodo data, had a 44-character alphanumeric. They can see patient sex, year of birth, not date of birth, and the first 3 digits of that patient's zip code, also known as the zip 3, and there are 880 zip 3s in the United States. You can imagine that when other data sets are linked, then the risk of re-identification, the risk of re-identification goes up. So what do you do then? That data has to be certified by a PhD statistician. They look at all the data fields in totality to ensure that the risk of re-identification falls below a certain threshold. So that process takes 6 to 8 weeks. Komodo and Komodo's client would then get like a 30 to 50 page report discussing the elements of re-identification risks. And sometimes those certifiers had to go back to Komodo and Komodo's client and say, hey, you have to remove data fields X, Y, and Z in order for me to certify this. So I'm really glad that it's rigorous, but I'm also glad that we can do this in the United States. This kind of work is next to impossible in the EU. In my experience and through my admittedly biased lens, it's a sound process, although I'm sure, I'm not an expert on all of this, and I'm sure that there are risks that I'm unaware of. So glad we're discussing this piece of it.
Yeah, I mean, I think to the points people have brought up here, we've really taken the approach of really having patient data on really like a need to use level. So patient age, sex, race, things like that, but nothing identifiable, and really trying to keep that as limited as we can to fields that are really relevant to patient diagnosis. And then we can do sequencing on patient data, but that's, a lot of this is like, we really, really need to be careful to maintain the trust that patients have placed in us. And I think that's true for all of us. For us specifically, it can feel really personal in that we are receiving a piece of a patient's tumor, and there's just a ton of responsibility that comes with that to treat that with the respect that and to value the trust that these patients are showing in us when they're consenting to having their tissue used and their tissue sequenced and giving out even this limited information to us. But it's just so important to make sure that I think we have as little information that could identify the patient as possible, and really are treating patients with the dignity that they deserve.
I don't know if any of you are getting dense genetic data on patients, but that, there is concern that that's inherently identifiable information because people are so diverse genetically from each other. Is that an issue with?
Yeah, I think that's something that we're really careful of in terms of how we store genetic data. Most of the laws have not caught up to a lot of that, but that's definitely something that bears concern, especially for what we're doing.
Do any of you have? Yeah, go ahead.
Misuse of information and data is definitely out there. I've seen pitches for companies that want to take genetic data, and when data becomes an asset, right, to help build a solution that can then be sold as a product. What ends up happening is that you really have to think about the ethics of where that data comes from, what it was originally intended to do and serve, and then also what it's used now for. And it's an interesting dynamic because especially with genetics, that is so specific to an individual, that being and using that for other purposes outside of its original intent, regardless of the intent and the good nature of the idea that comes out of it, there's a lot of ethics and there's a lot of discussion around that in the space.
Yeah, I mean, I think we've all heard, or many of us have heard the example of like the Henrietta Lacks, the cells that were taken from her, and everyone knows who she is at this point, and that's not something that she ever consented to, let alone her actual tissue being used. And I think that's something we really need to bear in mind and really be careful of with, like, yeah, the laws then said you could do that. Like, there wasn't anything specifically prohibiting it at that point in time, as I understand it, but really like thinking forward and thinking about how we can be responsible stewards of the healthcare data that we have is incredibly important.
Yeah, and I think to that end, with regards to genetic information, we probably really have to be extremely precise about what we're going to use that for, right? So if a company, again, like Cognoa ever wanted to capture genomic data, do they need full exome sequencing, or do they just, need to get and store information on, I don't know, let's just say 90 different alleles for some given patient, right? That's a lot less. The re-identification risk in that scenario goes down if that data were to be misused maliciously. So all good points by Marinka and Katie Rose.
And I mean, so you mentioned making sure that patients know what you're going to use the data for, and we talked about consent, but it seems like it's a challenge to make sure that patients really understand what they're consenting to. It's we all have advanced degrees and we're in understand the technical details of what we're working on, but patients are just trusting us to do something ethical with their data, or think we have their best interest in mind, but do we really think they understand what they're agreeing to in the consent document? How do you think about that, Vijaya?
Especially dealing as a B2B org, I don't think it's possible to convey the whole impact of what their data is being used for, right? I think more so the responsibility lies on the people handling the data. So the onus lies on the health plans, onus lies on the providers as to how they are handling their data, who are they partnering with, right, in terms of sharing their data, be it vendors like us, other risk adjustment agencies, any kind of outsourcing agencies that are helping them drive their outcomes. I think those companies own the onus, because there's so much that goes on with this data. We use it for specific purposes like driving outcomes for better health, checking utilizations, driving specialist care where needed. But how do you segregate all of that, and how do you get a common man to understand all of it, right? So I truly think that the onus lies on the companies that are handling this data.
I agree. Yeah, we didn't all take healthcare data use 101 in college, right? So, and the majority of people that are sharing their information for everybody to then use, especially in the age of interoperability and combining information, and it's unfathomable just to wrap your head around if you're in the space, right? And so I don't think that people really understand how their healthcare information is used to make decisions around better practices. And they hope and trust that, to your point, that people and companies are working with integrity. But at the end of the day, when you're a patient and you're sick, you're really not thinking about whether or not what insurance is doing with your data, or what the doctor is going to do with the information that he's keying into the EMR. You're just worried about getting better and well. And, that's where I think some of the patient advocacy areas come in to really help promote the transparency. And this all kind of comes together so that it really focuses back on patient care and helping the patient. So it's really hard because your data is everywhere. Whether it's linked to you or not, it's everywhere.
I'll add, to answer your question, Dan, is I think for me personally, having conversations with certain family members during COVID, it was really illuminating to see just how health illiterate certain people can be, and even the ones who are relatively well educated can misinterpret information very, very easily. So yeah, I think without question we need better rules, regulations, and laws surrounding how we make these disclosures, especially for genetic information, and how that could be used.
So I'm going to start, in addition to my own questions, I'm going to start interweaving some of the excellent questions that are being posted in the chat. And I encourage anyone who's watching this panel to please post your questions in the chat. Dr. Addy has a really interesting question, which is about, should patients be given access to their own data? What do you think about that in your context?
100%, full stop.
Yeah, there are laws now in place for that say that the patient actually owns their own data. You cannot be denied access to your health information. That includes scans, that includes anything, lab results, all of that. So you technically own your own data. I don't think that the public really understands what that means and how they can leverage it to actually promote their own better care, especially when you're going from one hospital system to another, and so that there's continuity of care there. So definitely 100%.
Yeah, agree. And as Marinka said, interoperability, the government is pushing big time towards that. There are huge strides being made towards it, where data information for members flows seamlessly when they move from point of care or when they need specialist care. Access to data where you have to request for records, that will be a thing of the past very soon. Data should be flowing freely, and the data is owned by the patient individual.
Yeah, and we've seen that in some of the clinical studies we've done. You can have, patients certainly own every piece of information that they give us. And one of the things I don't think I realized prior to starting this company is patient consent can be withdrawn at any time. So if a patient is enrolled in a clinical study with us and they say, hey, a year ago we sent tissue, I don't want to give you any more follow-up, and I want you to remove every record of my sample, every record that this ever existed. We have to comply with that, and we will comply with that, and we should comply with that. The data fundamentally really does belong to the patient.
How does that interact with the encryption of the data? Because presumably once the data is encrypted, it's very hard to remove the individual.
So we get, most of our patient samples that we get come with a unique identifier from the hospital we get them from. So we never know the patient name. All we know is this unique identifier, and we can remove every piece of data that's associated with that patient based on the unique identifier. It's written into all of the, for patient tissue, you have to go through a IRB approval and get, an ethical review of your study. And that's something that always needs to be baked in, is really making sure that patients retain the control that they deserve.
I'm gonna skip to Ignacio Albert's question. I'll come back to Anand's question later, but this is related. And Ignacio is asking, what about when a patient dies? So I guess one part of that question is, do you have to remove their data then? Does someone else have the right to request removal of their data at that point? Do you think about it any differently when a patient dies?
Yeah, so the patient typically will be written into their consent, what they would like done with the data when they die. Typically, the standard consent has that, has us retain that data, but we would certainly respect any requests from next of kin to remove that data.
Incidentally, my wife is the COO of a nonprofit called Stop Soldier Suicide, and one of the things that they're working on with data is it's called the Black Box Project, and they go to military members' families, and in this circumstance, these family members have already died by suicide, and they're asking for their devices to retrieve data, to try to look for signals that are in that data, to try to better predict what's going on in a patient's life before they do die by suicide. And so they do have to, my understanding is that the contract is pretty lengthy. There's a lot of disclosures, but they absolutely have to ask for permission and disclose a lot of what's going to be done with that data.
So Anand, Arika Ravula, I'm sorry for completely butchering your name, has asked a very interesting question about diversity of the samples that you collect. I mean, it's a known problem that a lot of the data that medical research is based on and genetic research is based on is from highly skewed samples of Western, wealthy, white samples. Is that something you're concerned about? And do you make efforts to diversify the data that you collect or work with?
I can answer that for us. We certainly will get whatever tissues we can from the partner hospitals we work with. I mean, cancer affects all kinds of people from all kinds of backgrounds. And it's an area where people are very often incredibly generous in terms of contributing to scientific research and to helping to prevent cancer or treat cancer better. But there's certainly still is a bias in terms of who gets care and who gets the most care. And so we're always looking to expand our network of clinicians and of hospitals that we work with and trying to move more towards community hospitals to help us get better representation there. But it's definitely something we keep in mind.
And from our perspective, aside from a research perspective, where we are trying to build algorithms that improve patient outcomes, in those cases, how we try to combat this is actually asking for the race and ethnicity, and then looking for more blocks of data there. So we are looking to get not just the healthcare data that pertains to individuals right now, but we ask for some historical information. We ask for maybe diverse states, areas, not just where we are performing some analysis. So we constantly ask for bigger blocks of data, reviewing what we have right now and hoping that covers the diversity aspect of it, just from a gender perspective, race, ethnicity, covering all of that.
Yeah, I would add the socioeconomic information also for SDOH and identifying and really honing in and including those determinants of health that are outside of the normal care is really important because there are so many other factors, and that's where the opportunity lies with precision medicine is actually looking at those factors that really affect how healthcare is delivered and also received.
I'll add that there are top-down efforts that are happening as well. So the FDA I think it was maybe late October said that companies who are pursuing breakthrough designation, so if you're a device and you want this accelerated pathway through the FDA, you have to show that you're going to recruit a diverse pool of candidates in your clinical trial. So those top-down efforts, I think, are really, really important. Komodo, the founders at Komodo had the foresight to know that those regulations were coming. And so with the Komodo data, you can augment it with race and ethnicity data. So it's tremendously valuable and hugely important that we are aware of this particular issue.
So Harrison Jung has another interesting question, completely different angle. I think related to the issues of privacy that we talked about before, which is blockchain. So the question is, this is an exciting new technology. People have talked about, using blockchain for electronic health records. I mean, what do you think? Do you think that blockchain is something that's going to be important in what you do?
So I think it's actually contradictory. So the privacy aspect of healthcare data and the strict laws governing it make blockchain really, really, really hard to implement, especially for healthcare data. That's been my experience and what I've seen in the industry so far.
It's very costly.
Yeah, can you say a little more? Yeah. So, anyone, I'm just curious just to say more about what the contradiction is.
So the contradiction is that blockchain makes data easily available, right? The data cannot be edited, but it is available easily for use through the blockchain technology, while privacy laws for healthcare data make that distribution, at least right now, very, very hard. And as Marinka was alluding to, and Marinka, you can continue the point, but it is extremely cost prohibitive to do so as well. Go ahead, Marinka.
No, and I can tell you that there's a significant amount of effort by the very large organizations, the Fortune 500 companies, to try to come together and create solutions, as well as smaller organizations that are technology savvy and in the niche market. There's even a Blockchain and Healthcare Today is a great journal if you want to learn more about that. But it's very hard to implement. I know people who have actually implemented a blockchain-based solution and then removed the blockchain component of it so that it could be used by the the clients. So it's not there yet, but the concept is promising, I guess I would say.
What about removing people who don't want to give consent anymore? That becomes hard on the blockchain. Does anyone want to take the pro side on the blockchain? Does anyone think it is? It's going to happen sometime soon in precision healthcare?
It's a blind spot.
Okay.
So I don't know.
Yeah, same here.
All right, so I'll take another question from Dr. Addy. He asked that if a patient dies from a genetically inherited disease, wouldn't that be relevant to their survivors who are related to them, and how, I guess, how is that issue of the relevance of genetic data for biological relatives, is that something that more broadly is something that you're concerned with in your work?
Yeah, so I can speak for us, which is that some of our contracts do specifically request that if we find anything that could be relevant for in terms of genetics, or if we find anything that could be really relevant to disease progression for the patient, and that is sort of part of the known standard of care in a way that our platform is not yet, that we give that data to the clinician. So if we have, clinically actionable genetic mutation data, or I would imagine things like exposures, but we don't really have great insight into that, that we would notify the hospital, who could then get in touch with the patient.
There are some diseases like Lynch syndrome and so forth that also have it's genetically linked to so notifying and being able to help people understand if they are at risk for some diseases that then put them more at risk for other things like kidney disease and much more other complications. There are factors involved, and it's an interesting question, but the linkages of genetically traced diseases, it's something that we should definitely address in the near future.
So coming back to the issue that we talked a little bit about before about buying and selling data, I'm wondering, do any of you purchase data or sell data or sell results of data analysis that you do, or the data itself? And how do you think about what, the ethics of buying and selling data and data analysis?
So I can talk about this a little bit from Episource's perspective. We don't sell data directly today, but we do market, or one of our SaaS products is the outcomes of that data. So one of the ways we use it, I'll share an example, is one of our clients is a nonprofit children's health plan, specifically focused on Medicaid. Using the data, though, what we are able to do is we are able to give them actions on who their providers are, who have the sickest members, right? We are able to, because a lot of these, they're here actually in Texas, and they're more located towards the border, so El Paso, etc., where there may not be that many clinics, there may not be specialists. So we are able to target specific diseases in their population and say, in these zip codes, you have these children who have the highest amount of, say, pulmonary diseases. You need to send some specialists over there. And so they are able to drive targeted action. So that's one way we use data to sell and provide better outcomes, right? We don't directly sell data. We do buy data. Again, we buy data to build our algorithms. So AI and machine learning algorithms that basically help us predict this, right? To do that, you need extremely large amounts of data. So we do go out in the market and buy pharmacy data or from these sources that the government has approved to be able to build these algorithms.
Anyone else want to jump in on the Jim?
Yeah, sure. There are hordes of companies that are selling data, right? Is it the right thing to do? I don't know that I'm necessarily the best person to answer that question. As I said earlier, I'm not the expert on the downside risks of it by any means. But again, my bias is that the potential of using this data for good is extraordinary. I genuinely believe that without having the opportunity to do so, I'm not sure that we can meet, the needs of patients, right? I think that having access to this data over the long run will really improve clinical outcomes and drive down costs. And that is something that our healthcare system, especially in the United States, desperately needs.
100% agree.
I would add that. Oh, go ahead.
I think from our perspective, really, we don't buy the data, we don't sell the data, but what we do is similar to what you were talking about, Vijaya, where we can find insights around what types of patients respond to what drugs. And that's something that we can use to partner with pharma companies who are looking into, say, designing better clinical trials and identifying the right patient populations for a drug that's maybe never been in a patient before, really identifying who will respond to it and who won't based on, genetic indicators or, disease subtype, like what type of cancer it is or things like that. But definitely nothing, related to a patient themselves or specific to that patient.
Yeah, I'll play devil's advocate here, though, if you'd like. So I understand that there's so much opportunity and the intent to and the mission, which is all of ours here, to improve health outcomes and improve care, is so core to our everyday, and the ability to use all kinds of unique forms of information and combine it, and using AI and leveraging data science and all of that to be able to translate it and be able to help one individual, even if it's one individual, is so motivating, right? But on the other side, is more data better? Like, we all the things that are in place, EMRs, all of the pieces, some would argue that some of the most broken parts of the healthcare system right now are tied to the best intent to capture data to improve outcomes and to be able to measure those outcomes, right? All of the EMR was put into place so that we can measure quality of provider practices. All of this comes, but it then starts to dehumanize the care itself. And so I would ask that people think about it and say, well, yes, it's going to make it better, and we're going to have better quality and better options and better regimens and treatments and wonderful options. Will live to be 100, but let's not forget about the care itself and how that care is provided, so that, because that's just as important, I think.
That was really well said, Marinka. Does anyone else have any kind of closing as we come to the end of the session and have kind of closing remarks, please, to make to the audience, or visions, inspiring visions for the future?
Yeah, I mean, I guess from my perspective, so much of medicine right now, and certainly 20 years ago, was really guessing and checking what would work in patients. And I think so much of our responsibility in terms of bringing precision medicine more to the forefront, and so much of where the field is going, is really trying to eliminate that guessing and checking, trying to eliminate using humans as test subjects, and really understanding beforehand how to take the best shots. And every part of this is really just, increasing probabilities of success. But I really think we're at a transition point where I'm really hopeful that 20 years from now, we'll see this guessing and checking of different drugs or different treatments or different, digital therapeutics as so outdated, and there will be so much more specific care and hopefully humanity brought to a lot of patient care.
Yeah, so I think that precision medicine by far has so much opportunity, and the benefits are countless. So it just need to be mindful of how we use it and implement it, and how it kind of falls into the care practice.
Katie, Rose, Marinka, Jim, Vijaya.
Yeah, I can't say it any better than what's already been said. So thank everybody for their eloquent thoughts.
Yeah, I agree.
Well, thank you, Marinka, Vijaya, Jim, and Katie Rose. This was a fantastic panel. We really appreciate your sharing your time with us today, and we look forward to seeing everyone at the next panel.
Thank you for having us.
Yeah.
Thank you.